Hi Year 12s, it's Mrs. Chips here. So this week's lesson is on ECGs, and I'd like you to work through the task set and the work on this video before we have our live session on Thursday, because we'll be using some of this in our lesson on Thursday. So first things, please can you make sure before you watch this that you've actually done the starter quiz on Microsoft Forms. The link to that is on our Teams page or on Go for Schools. During the video, can you make sure you're taking notes, jot down any key diagrams, include labels and annotations, so anything I add, include that. Any questions that I ask during the video, can you make sure you complete them in writing? If you need to pause it in order to do that, then please do. Any time where you need a bit more time to think or to complete your notes, pause the video. And then after the video, you'll need to complete the Kahoot quiz just to check your understanding of the key concepts. So we're thinking about ECGs. ECG stands for electrocardiogram, which literally, if we break that down, means so cardio comes from the heart, gram means a picture or graph, and electricity. So we're creating an electrical picture of the heart's activity. Now we do this by sticking little sticky leads onto the skin. And you can see on this picture there's a few, couple on the arms, there's a couple that will be on the ankles, and then you've got all these ones on the chest. Now some ECGs have different numbers of leads, it just depends on what you're looking for exactly. But all of them will be placed in specific points in order to measure electrical activity, and they're not directly measuring the heart itself. What they're measuring is tiny changes in electrical activity within the skin that are a result of the electrical activity in the heart, and it will compare the electrical activity in one place to another. So the images you get on the ECG are waves created by this detection of electrical activity at the skin and comparison between the different areas. But we can use that wave that we get to actually map the electrical activity of the heart. We can match it to different parts of the cardiac cycle and of the electrical control of the heartbeat. So this is an image of an actual ECG trace that you would get if you have an ECG done in the hospital. And you can see there's multiple lines, there's different label sections. So these are the bits that are comparing different signals that it's picking up from the different leads. So an actual ECG trace is quite complicated. It's difficult to interpret, and hence why doctors and nurses and medical practitioners get an enormous amount of training, because this is just a tiny part of their job, but you've got to be able to interpret this with a really high level of accuracy. At A level we look at a much more simplified version, where we're just considering one segment of this. We're not looking at the whole picture with all the waves produced. So I'm just going to switch over to the visualizer. So we can consider a single ECG wave like this. This is obviously a overly exaggerated, simplified version, but it has these different segments to it. So we start off with this little bump here. This is known as the P wave. We then have this bigger change in the middle here, which we call the QRS complex. So we can call that whole section the QRS complex. And then we finish off with this little bump at the end, which is the T wave. And each of these bits relates to a different part of the activity of the heart. Now have a quick think. If we're thinking of this as the whole heartbeat, so it's going to be the whole sequence of events, what do we think is happening at P? And then what do you think might be happening in the QRS complex, and then any ideas what T is. So just pause the video and jot down some ideas now. So hopefully you got some ideas for some of these anyway. So the P wave happens at the same time as atrial systole. Hopefully you can all remember systole meaning contraction. So our P wave coincides with atrial systole. So this bit of electrical activity, where is that going to be coming from within the heart? Again, pause it, have a think, what part is actually generating this wave of electrical excitation? Okay, so hopefully you've got that it's going to be from our sinoatrial node, the SAN. So when we're detecting this little wave of electrical excitation on an ECG, it correlates with the wave of electrical excitation that the sinoatrial node generates, which causes atrial systole. We then have a pause. So this little pause here, where there's no electrical activity, any ideas what might be happening at this point? Think about how it links to our sinoatrial node. So what we find is that this pause here links to, it's happening at the same time as the delay that we get between electrical activity in the sinoatrial node and electrical activity in the atrioventricular node. So this is that same sort of delay between our sinoatrial node and our atrioventricular node. And this is partly facilitated by that layer of non-conducting tissue through the boundary between the atria and the ventricles that stops this wave of electrical excitation continuing into the ventricles. Otherwise, if that conducting tissue wasn't there, there'd be no gap here. We'd have this continual wave of excitation starting with our little P wave, and it would shoot straight up into this QRS complex. But because we've got that boundary that insulates between the atria and the ventricles, and because our atrioventricular node pauses the electrical wave of excitation, we get this little delay, and it's very short. The whole of this sequence of events is 1 second or less. So this is a very short pause, but it's an important pause. Then our QRS complex, hopefully you've all worked out, because it is the biggest change, is going to be to do with ventricular systole. So this coincides with our ventricular systole, and we know that this requires a much greater contraction, so it's no surprise that the electrical activity is also much greater. So at this point, our signal, our wave of electrical excitation, has been passed from the atrioventricular node down the bundle of His and up into the Purkinje or Purkinje fibres, so that the contraction can start at the base of our ventricles. So we've gone from our atrioventricular node to the bundle of His, I'm just going to call it BOH, and then to our Purkinje fibres. And so this is the signal picked up by our ECG leads when we've got that electrical signal passing through those Purkinje fibres in the ventricles. And then the last section here, the T wave, this is where essentially it's a reset. this is where we have what we call repolarization. So whenever we have a signal within a nerve or within the heart electrical tissues, we call it a depolarization. And when we look at the nerves and how they work later on, we'll go through exactly why and what's actually happening on a microscopic scale within the membranes. But in order to be able to go through that process again, it's got to reset, and we call that repolarization. But come back to this when we look at the nerves. Come back to this and think about what actually might be happening along the membranes within these cells, because you should be able to piece together quite a lot more after that. Okay, so we're going to have a look at how different ECGs can appear. Obviously these are simplified because, as we've seen, the genuine ones are really quite hard to interpret. So we're going to use simplified ECG traces to look at some different conditions in the heart and how these ECGs can be used for diagnosis. So on screen right now at the top we've got a normal ECG. We can see the gaps between each beat are even, so we've got a regular rhythm, and we've got a time scale on this ECG trace where 5 squares is 1 second, and we can see that each beat is taking about 1 second, so that means we're around 60 beats per minute, which is totally normal. Anywhere between 60 and 100 beats would be considered normal. Beneath that we've got a trace where we can see the gaps between beats are longer, so therefore we've got a slower heart rate, and a slow heart rate is known as bradycardia. So we've still got evenly spaced beats, but the rate of beats is lower. So have a quick think about any situations where bradycardia might happen, and think about this as a normal process as well as a sign of disease. So what situations could this be something that happens normally, and what situations could this happen that might be a sign of disease? So the kind of situations where this could be normal could be someone who's an athlete, for example. So if you're super fit, your natural heart rate might well be below the normal range, and it's not a sign of anything to worry about at all in that case. It just means that your heart is working more efficiently than average, so it's not having to beat as frequently in order to keep your oxygen supply to your tissues high enough. So people who are super fit have really quite low heart rates, and it can be as low as 50 beats per minute, sometimes even lower than that. But they would still be classed as bradycardia. Another example could be so it could be a problem with your sinoatrial node. So sometimes people develop conditions where the sinoatrial node doesn't act in the way it should, and one of those results could be bradycardia. Also, there's some drugs and medicines that could also cause this. So this could be a sign of something else influencing someone's system, not necessarily an actual change within their heart. Okay, so next example, we've got our normal trace at the top there again, and then underneath we've got an example called tachycardia. So tachycardia is when your heartbeat is faster than normal, and it's defined as a heart rate above 100 beats per minute. The beats are still evenly spaced, so we've got a natural rhythm, it's just faster. So have a quick think about what could cause this, and think again about normal causes of it and also causes that could be a sign of disease. Okay, so tachycardia happens to all of us, frequently, because any time that you are straining yourself, even just a little bit, just walking for some of us, or running, going up the stairs, anything that requires a greater demand for oxygen means your heart is going to beat faster because you need to meet that demand. So tachycardia can just be a result of exercise, even minor exercise. However, it can be more sinister. So tachycardia can also happen as a result of your heart not being able to supply enough oxygen to its own heart tissue. So if you have coronary heart disease or heart failure, your heart is not able to supply enough oxygen to the muscles of the heart itself, and this causes the heart rate to go up because the muscles need more oxygen, and the quickest way for you to do that is to increase your breathing rate, increase your heart rate. If you have coronary heart disease through atherosclerosis, so that's when you have your coronary arteries have blockages in them, you are going to have parts of your heart muscle receiving very little oxygen, and therefore your heart rate could go up really high in response to this. It could again also be a sign of drug taking. So drugs that are stimulants in particular are going to cause an increase in heart rate. So things like amphetamines can have a really big effect on heart rate, so it could be the cause of this tachycardia. But also if you were to go into an environment where the oxygen supply is low, so remember what we were talking about with hemoglobin, different environments have quite different oxygen levels, and if you were to go to high altitude, for example, or if you free dived, so diving without scuba equipment, your oxygen availability in your environment is much lower there, and one of your physiological responses to that will be that your heart will beat faster to try and get that limited oxygen supply round your body quicker in order to try and get more oxygen to those tissues than it can working at a normal rate. So tachycardia can signal lots of different things. Okay, next example here is something called an ectopic heartbeat. So again, we've got your normal ECG trace up the top, and below we've got an ECG trace where you can see an extra wave just after the third T wave. We've got this extra big wave known as an extra systole. This means the heart has done a little extra beat where it's contracted when it shouldn't have, and it's often followed by a longer pause before it goes back into rhythm. So an ectopic heartbeat is a short temporary change in the rhythm, and it's normally an extra beat followed by a longer gap before the next beat, and it's actually really common. So ectopic heartbeats, most people will have one ectopic heartbeat or more every day, but you're probably not aware of them. But just occasionally you will sense it, so you almost feel like your heart, people say your heart skipped a beat, or that you feel a little flutter. So sometimes you can have an awareness of these ectopic heartbeats, but most of the time you wouldn't notice it. It's only a problem if it's happening really frequently. So if it's like 1 or 2 a day, that's not a problem at all. But if it was happening every few minutes, you definitely need to get it checked, because it could be a sign of a more significant problem. Now, it can be caused by really quite straightforward things. So ectopic heartbeats can be caused simply by drinking too much caffeine, and some of you might have experienced this where you feel almost a little bit jittery after too much caffeine. It can also be caused by smoking. So again, nicotine is a stimulant, and it can cause these ectopic heartbeats. Stress and anxiety can cause these, and also feeling an ectopic heartbeat can exacerbate that stress and anxiety, so you can get into a bit of a vicious circle there. but it could also be caused by something like low potassium levels. So your mineral ion balance is really important for your heart electrical activity to actually work properly. So an imbalance of minerals could have caused this. Okay, next example is something called atrial fibrillation. So atrial fibrillation, it literally means random contraction of the atria. So when you'll see on things like Holby City and stuff where they talk about people going into atrial fibrillation, and they use those paddles to shock the heart back into its normal rhythm. Essentially what's happened in fibrillation is your sinoatrial node cells are no longer working together to create that one wave of excitation. They've started firing a little bit randomly. So some cells are starting the wave of excitation at one point, some at another, and so you end up with this contraction that's also a bit random. Now, it often also causes an abnormal rhythm, and the ventricles will also go out of rhythm as a result, but they tend to still be able to function okay. Now, atrial fibrillation generally is caused by an issue with the sinoatrial node, but it is found to be more common if you have other conditions like high blood pressure, atherosclerosis, heart valve disease, and some infections like pericarditis, which is an infection of the actual membrane around the heart. So it's a problem with the sinoatrial node, but it can be linked to other things. A slightly, well, significantly worse problem is ventricular fibrillation, which we have here. You can see the difference. Atrial fibrillation, you've still got a fairly normal QRS complex, but it's not spaced evenly. With ventricular fibrillation, the electrical activity is all over the place. In this situation, this person is seriously at risk of death because they are not going to have efficient filling and emptying of their heart in order to supply that oxygenated blood. So ventricular fibrillation is a really significant problem, and this would require immediate intervention. Often with fibrillation, pacemakers are used to fix the problem. Okay, next we have a very common condition here. It's called sinus arrhythmia, or respiratory sinus arrhythmia. And what happens in this case is we've got variation in the gaps between heartbeats, and you can see that by longer gaps between the QRS complexes to begin with, and then shorter gaps. And with sinus arrhythmia, it's linked to breathing in and breathing out. So people who've got sinus arrhythmia, generally when you breathe in, the heart rate goes up, and when you breathe out, the heart rate goes down. And it's actually really common, particularly amongst teenagers and those in their young 20s. So some of you might actually experience this, and it won't affect you at all. So sinus arrhythmia isn't really something to worry about. It's just a feature that you find on some ECGs. And then the really big one, it's cut off the words at the bottom, but this is myocardial infarction, or an MI, which is the proper word for a heart attack. So in this myocardial infarction, you can see multiple changes over time on an ECG. So it's not just one thing that will signify it. It depends on when the ECG is taken in relation to when the heart attack happened. So some people who go through a heart attack will seek medical help immediately because they have acute chest pain. But other people will kind of brush it off as something minor and might not seek help for a little while afterwards. My dad is an example of this, because he had a heart attack a few years ago and was convinced it was just a little bit of pain. He didn't tell my mum till the next day. She freaked out and dragged him to the hospital, and turns out he'd had a heart attack. But so over time you see different changes. So there are several things you might see on the ECG of someone who's had a heart attack. Often it's changes to do with the T wave and the Q part of the QRS complex. So you can see initially up here where we've got the initial onset of the chest pain, and we're actually getting effectively an injury to the heart is happening at this point. This ST segment is raised. So a high ST segment is a sign that a heart attack is actually happening now. What you find over the course of the following 24 hours is the T wave inverts. So we can see on this second picture, instead of dipping up, it dips down. So this is a sign that someone very recently has had a heart attack. If people have a particularly bad heart attack, we often see this drop in the Q wave, or a change in the height of the QRS complex, and this can start within an hour. So this is an acute infarction, and we can see here on an old infarction, so someone who's had a heart attack but it could be quite a long time ago, there will still be a sign of that. So the ST segment's back to normal, or normal-ish, but the Q wave forever remains changed. So it's a sign of permanent damage to your heart, essentially. So we can see multiple different signs here, and you can see the differences are subtle. So a doctor needs to be able to interpret these with accuracy, and generally this comes down to them having lots of practice during their training of looking at loads of different ECG traces and practicing interpreting them. Now at A level you're not expected to have that level of skill, but you are expected to spot a range of common conditions, so bradycardia, tachycardia, atrial fibrillation. Those are the more standard ones that will come up at A level, but it's worth being aware of the whole range that we've got in here. So what I'd like you to do now that you've watched this video is to complete the Kahoot quiz. The link for that is on Teams or on Go for Schools. So make sure you've done that, and then jot down any questions that you might have about any of the content of this, ready for our session on Thursday, so that I can help you out with any things that you just need a bit more clarification on. So go back through everything and think, actually, do you know what, I don't understand that bit, I'm going to check that with Miss. Jot that down so you remember it on Thursday.